Hi, we're going to talk now about hip replacement. We're going to go over the basics of hip replacement, what it is, what to expect, and things like that. In prior talks, I talked about hip pain, what the sources could be, as well as treatment options for hip arthritis. And now we're really just going to focus on hip replacement itself. So we'll talk a little bit about the hip joint and what a replacement is. So first, hip joint wise, let's look at a little bit of anatomy, and then what happens with the hip when a hip is arthritic. The hip is a ball and socket joint, and the pelvis, which is connected to your lumbar spine and your back, has the socket, and then the ball is the top of the femur. Those have cartilage on the end of those, and that ball and socket joint of the hip is deep within your groin, and that's what that looks like. So this model kind of shows a hip that's enveloped in muscle on the patient's right side, and that is the muscles that surround the hip joint. The hip joint is deep within that muscular thigh. The red line there is the incision that we make, and the muscles spread apart to get to a hip replacement and an anterior approach hip replacement, and then we get down to the hip joint. And then that clear model on the other side shows a hip replacement. And so basically those bones, which are now clear in that picture, show the implants that we put inside the femur bone and inside the socket to recreate that ball and socket joint of the femur, and that is a hip replacement. So the hip itself is a ball and socket joint. Um, and we'll talk a little bit about the approaches to the hip joint and how we get there. So, like all joints, the end of the bone is covered by cartilage, and so the ball and socket joint has that blue stuff on there, which is cartilage, represented there on the top of the ball as well as inside the socket. And then a healthy hip has nice cartilage with a normal space between the ball and socket joint and a nice smooth joint. When that cartilage gets fragmented and broken down and lost, which does happen over time with osteoarthritis, that's when cartilage loss occurs, and that is what osteoarthritis is, and that can cause pain, inflammation, swelling, and cause significant quality of life restrictions. This is what that looks like on an x-ray. So if you have a hip joint, which is a ball and socket joint, at the top of the ball, you can see a space between the socket and the ball. That's the space where the cartilage is. Cartilage is radiolucent, which means it does not show up on your x-ray, but the space between the ball and the socket and that hip is filled with cartilage. And so nice thick cartilage is what buffers the space between the ball and socket. Cartilage is low friction, it's smooth, and it prevents any grinding or irritation in the joint. And a hip with severe arthritis, on the other side, you can see a hip that has no space between the ball and the socket. That is severe arthritis. And so those hips tend to get some bone spurs on the periphery, as well as complete loss of joint space. That's a severe arthritic hip joint. All joint replacements replace or resurface the joint with man-made material. So basically this material eliminates the bone-on-bone contact, and it's also insensate, so it has no nerves, and so it can't transmit pain. And that's what replacements do. Replacements get rid of the bone-on-bone contact in order to decrease overall joint pain. So we'll cover the hip replacement device itself as well as a surgical technique to perform the operation. Here's some x-rays there of a hip with arthritis and a hip with hip replacement like we looked at a little while earlier. And now let's look at the implants, the materials, as well as talk about the history and longevity of hip replacement parts themselves. So this image shows a arthritic hip and implants and components, and then what that looks like inside the body. You can see that the joint itself, which is again a ball and socket joint, when the cartilage is gone, can cause pain deep in the groin there. And so with a hip replacement, we get down to that level of the bone and we take that ball off essentially, and then we replace that with the man-made parts. The femoral stem component, which you can see at the image on the right, is that piece of metal, usually titanium, which goes inside the femur, and that is broached inside the femur with a device that allows us to get the appropriate size of the implant inside the bone. And it's usually coated with a porous surface that allows for ingrowth of the bone onto that implant. And for that reason, that really provides for some really good results with long-term longevity of those implants. So then the femoral component goes inside the femur. The femoral head, which is shown there, is that pink thing. That is modular, meaning that it can be taken off and on the femoral stem. and different sizes can be used. And that femoral head is either made of ceramic or metal that goes on top of the femoral stem, and that's the ball. And then we have the socket side. So inside the pelvis goes the acetabular shell. The acetabular shell is metal that also almost always has a porous ingrowth surface on the inside aspect of it, and that allows for bone ingrowth into that cup with great results at that. Inside that cup goes a polyethylene or plastic liner, most commonly, and that goes and fits and locks inside that cup. And so the articulation of that entire process and entire construct is the ball inside the polyethylene insert. So the most common bearing surface articulation in a total hip replacement is either a ceramic or metal femoral head inside a polyethylene piece of plastic. The results of that longevity-wise has been incredible. The modern wear rates of metal or ceramic heads on modern plastic components is incredibly low, such that the likelihood of a hip wearing out in 20, 30 years time frame is low. So we'll talk a little bit about what can happen to hip joints in long term, but overall it is one of the most successful procedures at getting rid of joint pain, one of the most satisfying procedures to patients, and it's a really durable surgery in the sense that the likelihood of long-term survivorship of these implants is really incredible at this point after over 50 years of engineering. But these are the components. So again, arthritic hip and the implanted components, and then the completed hip replacement. And then these are the separate components, the acetabular cup, the plastic insert, the head, and the stem. Let's talk a little bit about the surgical technique of hip replacement. There are different ways to get into the hip to do the replacement, but essentially no matter how you get into the hip, the end result is similar in the sense that components that I just showed you, recreate the socket joint of the hip and try to get rid of hip pain by doing that. And again, that's extremely good in terms of overall results at achieving that goal. The ways that there are to get into the hip, there's multiple. The two most common are what's called anterior approach and posterior approach. An anterior approach uses an incision in the front or upper outer aspect of the hip. The posterior approach uses an incision in the back and side of the hip. The posterior approach goes through the lateral side and the back of the hip into the gluteus maximus muscle, and then the external rotator muscles are removed from the back of the hip, and then the hip procedure is performed similarly by taking the bone off of the ball off. The anterior approach utilizes that incision in the front. We split the fascia, which is a thigh surface coating basically, and then get down to the muscular layer and move those muscles to the side and get down to the level of the hip joint and get to the femoral anatomy in order to get that ball out and to perform the procedure. So those are the kind of different ways to do the hip. I tend to perform almost every single surgery I do through the anterior approach. That was really one of my expertise areas, and that's one of the things I do a lot of in terms of both initial hip replacements as well as revision hip replacements, and something I teach surgically to other people. This is kind of the incision of the muscular layer and that red line where we separate the muscles to get down to the hip joint. And then the hip replacement itself is that acrylic clear model where the ball and socket joint are replaced. So, especially with the anterior approach hip replacement, one of the nice things about that is we're able to perform the surgery with the aid of fluoroscopy or live x-ray. So this is an x-ray image during a hip replacement. And in this case, what we're doing is we're reaming the cup. And so that circular reamer reams out the socket cup in order to place the metal cup that we will put in. And then that liner goes into the cup. So this is a preparation of that socket part, and then the locking mechanism between the liner and the metal shell keeps that liner in place. And so that is the initial reaming. This is with the socket placed, and so now that socket is in there in nice position. The plastic liner, which you can't see on the x-ray, has been put inside there. So again, an anterior approach is nice. We're doing all this under x-ray guidance. After the cup, we move on to the femur. So we expose the femur and we put in what are called broaches, which are basically implanted devices that go inside the bone to increase the size of the allowable space in order to get to the diameter that we think is perfect in order to fit inside the bone. And so once we get these implants in, we actually can trial the components in order to figure out what exactly we were doing to your anatomy in terms of recreation of your leg length and offset, which we'll talk more about later, and decide whether or not we like this construct before we sort of finalize everything. So when we're performing trialing, we don't put in permanent devices yet. We really assess the stability and the leg length and all the changes we're making in order to really figure out if we want those to be the final sizes. So once we are happy with everything, we take the trial femoral component out. We put final components in place, and then we close the tissues up. And so that's a hip replacement. The process itself for hip replacement, most common, just normal, straightforward hip replacements take about an hour. So I'm going to go over a few frequently asked questions about hip replacement, one of which we sort of talked about, which is how long will it last? Modern hip replacements are likely to last outside of catastrophic things like infection or falling and breaking it, upwards of 20, 30 plus years. So these are really incredible, very durable things that we've created and engineered to the point that they are incredible at this point and very good at longevity. People ask, does the implant weigh more? For the most part, the implant weighs about what we take out tissue-wise, so not a big weight change in terms of what's put in. You cannot get osteoarthritis in a total hip replacement because the entire joint is replaced, so you no longer can get osteoarthritis in a hip replacement. Will it set off metal detectors, and do I need an airport security card? You don't need an airport security card because so many people have had hip and knee replacements that it's just a very common thing, and everybody goes through metal detectors and x-ray devices. It will generally set off a metal detector, most commonly with the amount of metal that's in it, but again, this is usually not an issue with modern airports because x-ray machines are available, and you tell them they had a hip replacement or knee replacement, and they see that on the x-ray. Um, One of the issues that we talk about and ask questions about is what kinds of materials the implants are made of. We talked about this before. Most commonly, the stems are titanium. The femoral heads are either ceramic or metal. The plastic liner goes inside the cup of the femur. That's also made of metal, most commonly cobalt chrome. Those are the most common situations. There's some implants that are made of titanium instead. I'm sorry, some implants that are made of different types of metals instead of titanium. But for the most part, that's the most common combination of the implants and materials that we use. An issue that occurred fairly long time ago now, thankfully, with hip replacements was a metal-on-metal hip replacement. So years ago, about 10 to 15 years ago, industry came out with some hip replacements that were made of metal on metal, which was basically a metal ball with a metal socket. And the theory behind this was that at that point, the plastics were the problem in hip replacements because they would wear out more commonly with older plastics. And so to get around this, a hard bearing surface like metal was thought to be a good idea. It also allowed for a larger femoral head to be used, which could decrease dislocation rates. So especially for younger people, people thought that this might be a good idea. And so a large metal head with a metal liner was introduced. This was FDA approved and implanted in lots of patients. And subsequently, we found out that there were issues with metallosis, specifically cobaltism, which is release of cobalt metal ions in bloodstreams, which can cause problems locally as well as systemically in patients. So this is no longer done for the most part and kind of a thing of the past, thankfully, but was a tough time for joint replacement. And thankfully, I was a bit behind this by a few years, and so did not do these, but they are some difficult situations when they do not go well. So you may hear about that, and those are situations which we do not see much of anymore in the absence of performing those metal on metal hip replacements. Patients ask, how does the implant stay connected to bone? Almost all hip replacements are not cemented, meaning that we don't use cement to put the components in. Sometimes for fracture cases or for some people with some really poor bone, we will use cement on the femoral side. But most primary normal hip replacements in people with good bone quality are what's called uncemented, which means that we put the implant in bone directly. The implant has an ingrowth surface that is sort of like a coralline structure, and the bone actually can grow into that surface of the implant. And that's one of the reasons why these things last so long, because they essentially get incorporated into the bone and survive there and really have a rigid fixation. And so, so that's how most joint replacement or hip replacement components act. What bad things can happen to a hip replacement? So some things to know about risk-wise and think about longevity, survivorship-wise. So things like bone fracture. So for instance, if you fall off a ladder, you can break the bone around the hip replacement, of course. The implant can fracture, although the fracture rate of modern implants is incredibly low. Hips can dislocate, so the ball and socket joint of the hip in the replacement are not connected. What keeps that ball and socket in place is the muscular forces and the soft tissue constraints around the hip joint. And in general, those are very, very good at doing that. And that's one of the reasons why another reason why these components last so long is that there's not a lot of friction between the components. There's not a lot of linkage between the components. And so there's not a lot of stress, which can do things like loosen the cup. But for that reason, that ball can pop out of the socket. Rarely, the rates of dislocation in most studies are between 1 and 5%, tend to be a little bit lower in studies with anterior approach hip replacement, and overall are very low in general. But something that can happen to hip replacements, which you'll hear about, tend to happen less and less commonly. I would say these days with more modern techniques, and again specifically anterior approach hip replacement tends to have lower dislocation rates. The components can wear out most commonly, especially 10 plus years ago. Um, the plastic components could oxidize and cause some wear debris and wear out over time. That can still happen in modern hip replacements, but the wear rates of modern plastics are much better. And so that's the reason for the increased longevity and life expectancy of these implants over time. And then there's a condition called corrosion that can happen. This is a relatively rare situation in which there can be some corrosion of metal ions at the most commonly these days the head neck junction. Again, fairly rare phenomenon and a bit debatable, but can be a source of issues with some people rarely. Let's talk about leg length and offset. You probably know what leg length is because that's pretty intuitive. It's the length of your legs. The offset is the horizontal distance of your femur from your pelvis. So if you think about your leg length, that's the longitudinal distance between the femur and your pelvis. The horizontal distance from your pelvis to your femur is what's called the offset. So what do we do to make sure this is right, and how do we make sure people don't have significant leg length issues? So if you look at an arthritic hip, this patient's left hip is really arthritic, no more cartilage space, big bone spurs, and that's a bad hip. So most commonly in arthritis, patients lose a few millimeters of length because that cartilage space is now gone. Rarely, sometimes people lose a lot of space. So if they have collapse of their femoral head, their femur can migrate up and they can have an inch or more of leg length discrepancy truly through the hip joint. But most of the times with regular old arthritis, we're dealing with single digit millimeters of difference. And so what we do is with all the x-rays we get of patients' hips, we use a templating ball, which is in the middle bottom of that x-ray. That's a standard diameter ball, and that will tell us that that image is scaled. And so therefore we can use computer software to use the scaling ball to say, okay, if that's X millimeters, then these parts are this big, and we can overlay those parts onto your bone and figure out what size we're likely to use of the cup and the stem and the head ball, and then we're going to put those parts. And so that all of those things with the aid of all this stuff before surgery, we can do what's called template, which is basically to get an idea about what we're going to do during surgery in terms of implant size and location, so that we can figure out what we're likely to need during surgery and where we're likely to want to place the components to get you the length that we're desiring. So in this person, for instance, we put down that the patient is short 5 millimeters. That means that that right side that we're replacing is short 5 millimeters compared to the left. So we know, okay, well, that's our goal. We might want to give that patient back 5 millimeters. Okay. And then again, the horizontal distance, which is the distance between the pelvis and the femur, we're trying to recreate that distance as well. So we've done it. So before surgery, we've kind of planned what we think we're going to do. And then during surgery, we execute it. So in an anterior approach hip replacement, remember, we're taking x-rays. So we can look at those x-rays with trial components in before we finalize anything, and we can change things to get things right. So a long time ago, 2015, I copyrighted this overlay that I used for a long time to help recreate leg length and offset, basically putting it over top of the pelvis and figuring out where the anatomy laid relative to the opposite side, and figuring out how much length and offset we were changing on the patient, and then dialing that in with this, what's called an overlay. These days, a little more commonly, I'll use some computer software that essentially does the same thing. We shoot x-rays before surgery and then during surgery and get an idea of what kind of changes we made, and we actually can get a numerical number that tells us, okay, right now with what you've done so far, you've added 3 millimeters of length, and your goal was 4 millimeters. So you're really, really close to what you wanted to do, and that's what your leg length is, and then your offset is X, too much, too little. And then we can change things. We can change the location of the femoral stem, and we can change the size of the head ball to change those parameters. And we can actually use a grid that will tell us what's going to happen when we do that. So this is pretty cool stuff, and it's one of my nerdy passions about, among other things, about anterior approach hip replacement. But that's kind of a cool, kind of technical, sophisticated thing to do to really dial things in to make sure everybody's happy. So to find out more information about hip replacement, my website has some more talks about hip pain origins and treatment options and hip replacement, as well as the surgery day, what to expect. Also some good sites like the American Association of Hip and Knee Surgeons site and the American Association of Orthopedic Surgeons site are really good sites to look for objective, good information. Remember, stay away from disinformation, bad sources, anecdotal evidence, and anything where people are trying to sell you something. All right, well, thank you very much. I hope you enjoyed this. You learned a little bit about hip replacement, and I hope it helped. Okay, thank you. Bye.